So I alluded to pelabresib a little while ago, and I will say that that comes to mind as one of the promising combination strategies with ruxolitinib again in the treatment naive space, JAK inhibitor naive space. They did this large trial called Manifest 2, which had a lot of positives, but like I alluded to, failed to meet that symptom benefit. Uh, you know. Threshold, significantly at week 24. So no matter how you looked at it, whether it was TSS 50 or this mean or absolute change, in mean TSS, they were not actually statistically significantly able to show an advantage. Now, however, they did have many positives, and that's why I bring it up as one of the more promising agents. There was a near doubling of the spleen response. There was around a doubling of the patients who had both spleen and symptom response. All favoring the investigational arm. There was some very nice reduction in bone marrow fibrosis, cytokines, which we know are targeted by pelabresib in addition to ruxolitinib. So there was a lot of positives from the trial. However, it has not led to approval yet because of that symptom endpoint not being met. And this drug, continues in development. In fact, that same trial is still, it remains blinded. People are being followed. We just had the 72-week data come out at EHA last month in June 2025. So that's there. And then there are other, compounds being looked at in the naive, JAK inhibitor naive space, like you asked, but we have less info there. So, for example, the Insight BET inhibitor, INCB 57643, is being, combined right now in the clinic in JAK-naive patients with ruxolitinib. We don't have data on this yet. So we do have data on this combination in the suboptimal setting where it's added on to ruxolitinib or as a single agent in patients who've sort of failed, ruxolitinib treatment or JAK inhibitor treatment. But we don't have JAK inhibitor naive data with the combination yet. And also, very excitingly, we saw some data for the first time in ET at EHA late breaker session at EHA on the Insight mutant calreticulin antibody, and that too, may enter the frontline space in combination with ruxolitinib. Again, hasn't yet, but that is something that is exciting, just mechanistically, and just because targeting mutant calreticulin in people who have a mutated CALR gene is obviously of interest. But I do want to come back to selinexor for a moment. And there is a very innovative trial called Sentry-2 that we haven't talked about that is also actually a frontline trial. And that's a JAK inhibitor naive. And that's what I mean when I say frontline trial, where patients with lower platelets, not super low, but from 50 to 150, so you could call it moderate thrombocytopenia, these patients who it is difficult to give a high dose of ruxolitinib, you certainly cannot give them 20 BID, for example. And we know from recent work that 20 BID is the most effective dose of ruxolitinib. So in these patients who are frontline, JAK inhibitor naive, but they have platelets between 50 and 150, you can, at best give them, 10 to 15, milligrams twice a day. In these patients, the Sentry-2 trial actually starts with selinexor. So it challenges the paradigm we've had for so long of starting with a JAK inhibitor. It actually starts with selinexor, but as a nice safety, if you will, thing that is built in. After 12 or 24 weeks, if you don't have enough of a spleen response, like you've not had a 10% or greater reduction at 12 weeks, or a 35% or greater reduction at 24 weeks, you can add a JAK inhibitor. So you're on selinexor from the get-go. So this way we'll get to know kind of clearly what selinexor alone does in the frontline setting, which is not something we know. Because the other trial is in combination, right? So this will give us an idea of that. And again, like I said, because this is a new paradigm and we've always started with the JAK inhibitor, they've nicely allowed adding a JAK inhibitor down the road at 12 or 24 weeks if the response is not good enough. And this is exciting because, selinexor has been studied as a single agent, but not in the frontline setting. So we have good activity from the essential trial, for example, which was in post JAK inhibitor patients, as well as another study that is known as the I believe the 035 study that was also presented at EHA, export 035 study, where also I think around 24 patients, a smallish study where it was looked at after JAK inhibitor, and we know the drug is active in that setting, so it will be intriguing to see what it might do in a frontline population.